my purpose was to tell what can be the future for family medicine through distance education. That was the main objective. But there is no audience to take the matter. So I will make it a brief presentation. You see, in our previous session we listened that in Sri Lanka the family medicine is 6 years duration after MBBS. In Canada they are giving even 3 year, 4 year. In West Bengal they are giving even 1 year after MBBS, and they are, so the issue is what product we aim at, to whom we will call a family medicine physician, how much skill that person should have. Unless we standardize that, this controversy is going to take place. Like in the MCI, whatever curriculum they have finalized, in the last international conference, a task was given to finalize the skills that a family medicine physician is supposed to learn. So unless we know that, if I know that, okay, like 99 topics Canada has identified, if we identify the number, then the duration can be planned. Whether that 99 can be taught in 1 year or 2 year, 3 year, that duration can be planned. Like in the CMC Valor, they have planned 2 year. Now they are going for 3 year masters. They started with PG diploma. So what I want to tell in IGNU, what my talk will be, that it is a platform. We can utilize this platform, but we have to first fix our objective. For what purpose we want to utilize, and what is the outcome objective that we want to achieve. Now I will quickly go through the slides. These are basically conceptual issues that I wanted to bring in. You see, IGNU, we listened in the, since morning, we are trying to make a partnership with all the foreign universities, as if India does not have the potential. And the issues that I was seeing, whatever content we are teaching, in Indian context, if you see, the community medicine department curriculum is teaching that. Today what is happening? We are diluting the MBBS standard. We are not giving them enough hands-on skill. Internship, they are just skipping the internship, preparing for PG. So what is happening? The MBBS that a MBBS is supposed to learn the skills, he is not learning that skill. And we are telling that he has to learn so many skills and the duration has to be 2 year, 3 year, 4 year. But if we focus that if that learn all those skills, then there is not much thing left that he can be have deficiency. Similarly, IGNU was created with a national jurisdiction to lay down standards in open and distance learning. Whatever we are listening from the Edinburgh or from Canada, this standard in Indian context is to be finalized by IGNU. That is what the mandate was. It is a university system having vice chancellor as the head. We have schools and divisions, which are the academic bodies. We have the regional centers, which are the implementing bodies. Then the study center like medical college, where actual training takes place. I want to focus these 2-3 slides. I want people to understand it so that the next things will be easier. When we are telling open education, it is basically a philosophy. And when we are telling distance education, that philosophy of openness or the flexibility can be taught through a distance or through face-to-face mode. In today's context, blended learning is being taught. When we tell that there has to be a face-to-face component and there has to be openness, then we call it a blended learning. That is what IGNU is practicing. The basic issue is, there is a learner, a student of family medicine, who has to be taught, and the teachers and the student, they will create an environment of learning. And that environment is created in a face-to-face scenario when there is a residential training. It is a correspondence mode when there is a correspondence. And when there is a internet mode, we call it online training. And when multiple media play the role, we call it ODL, open and distance learning. The issue is multiple media can have a role, but the face-to-face component is not sacrificed. This is the most important issue that I want to bring. When we call distance education, don't think that the students are at a distance and not then how they will learn the practical component. The most important part is face-to-face is an integral part of the open and distance learning. So the principle is teaching learning is an arrangement. This arrangement we have planned consciously in a classroom, or this arrangement can be done in an outside classroom. I will give an example of cooking. Consciously we plan that cooking in a kitchen room has to be done. There has to be a chula, there has to be utensil, all this. So an environment is created where cooking will take place. But that cooking can take place in the roadside. Roadside vendor, he is also doing the cooking. When you are going to picnic, you are making a makeshift arrangement and you are also cooking. Then what is the difference? Difference is, can you prepare a tasty and eatable ready food which is not contaminated, maybe healthy food. If healthy and the tasty food can be prepared on a roadside situation, then it can qualify the same quality as it is being offered in a kitchen room. Therefore, teaching learning arrangement, what I want to tell, that whatever we are learning in a residential training face to face, if we can have the outcome, same outcome in a different setting, then we should accept it. Just like we are accepting the roadside vendor food. So the implication, there are a lot of theory in distance. The implication is learning can take place at any environment, and this, to start, pace and stop learning, there has to be freedom to the learner. I am a student, now I want to learn or now I want to relax, that is up to me. So that learner has the freedom to start, pace and stop learning. Learning activity is more important than the teaching effort, and the assessment should be independent of consequence, method, place and pace of study. If my assessment is impartial, it does not matter how a student has been taught, then I can assure my product, the outcome. The issue is how we can plan quality training in a distance mode. How we learn. Let us go to our medical days in MBBS days. How we learned enlargement of liver, for example. We learn the theory part, then it is demonstrated in a bedside situation. Some student practices under the supervision of the teacher. Then we see more and more patients. When maybe in the evening we come, see the bed sheet, and we see, okay, in the case sheet it is written enlargement of liver, and we verify our diagnosis is tallying or not. That is practice for self-confidence. These 4 steps can be done in one setting, or these 4 steps can be done in a different setting, as I gave the example of picnic and the kitchen room. In IGNOU, it is a distance education institution where we teach the first step of learning, that is the theory part. The demonstration can be taken place in a tertiary health setup, that is a medical college. The supervision can take place in a district hospital, a secondary health setup, where a specialist is available. To teach and to demonstrate the enlargement of liver, one does not require to go to a medical college. Even a medicine specialist in a district hospital can do it. So why we utilize the time of the medical college, which can be utilized for some other purpose? Then at our workplace, because they are already MBBS doctors, it is after MBBS, he can practice more patients in his own clinic rather than spending residential training in a medical college setting to self-practice. So, similarly in a surgical training, the pedagogy can be further divided. Text reading, observing the procedure, assisting in operation, then perform with assistance, perform under guidance, perform independently with referral support, and perform. What I want to tell, all these steps are being done in one setting in a medical college. All these steps can be segregated and can done in different settings so that we can utilize the material, that is the patient, available in the periphery. Now we are using as a teaching material, we are using those patients who are coming only to medical college. Therefore, there is a big rush in the medical college, teachers are overloaded and the teaching is affected. Can we segregate this? That is what the benefit of the distance education. So this is an arrangement. I will not go into details that how these 7 steps of learning in a surgery can be done in a distance education mode without compromising the quality. So basically the pedagogic design is cognitive learning can be done in a distance education institution. Initiation of psychomotor learning, hands-on training, can be done in a tertiary setup. And the reinforcement of the more of the learning, skill development can take place in periphery, that is a district hospital. And confidence building can take place in a resource constant info. That is very important. What we are, like in the morning we are being told, you learn delivery in a medical college. Tell the student next day to go to the village and conduct a delivery. He cannot do. Because he has not been taught in a resource constant environment. Therefore, if consciously in our teaching design we put that okay, he has been given cognitive component, psychomotor component, now let him learn in a resource constant environment also and let him be assessed in that environment also. And after that if we certify, that certificate will work. So in ODL or open and distance learning, how we teach? The theory component is taken care, the content delivery like self-learning material, audio video, interactivity can take place in a contact session, teleconferencing, assessment, that we give the assignments which can be even online and there can be credit transfer. Quality assurance of theory is done by separate passing in torment and question framing at appropriate level. For example, if you ask a question that list the 10 causes of postpartum hemorrhage, student can mug up and write. But if you frame that at an analytical level, at a judgmental level, he cannot copy. So the framing of the question is also very, very important. So quality assurance takes care of all these things. Practical component. Content delivery can be done through manuals, Cordal Atlas, chart books, and the learning process, standardized posting plan. You go by each, like I list, there are 10 skills. Each skill I will plan where the posting will take place. How much hours in medical college, how many hours in a district hospital, which logbook he will maintain, all those detailed posting plan. Demonstration, supervision, one-to-one mentoring. Like in a medical college, one-to-one teaching is not possible. But if I post them to a district hospital, I tell, okay, there are 600 districts in India. If 600 students are there, I can have one-to-one posting in every district. So what I want to tell, we can bridge the barrier between the academics and the so-called clinicians. We tell the district hospital person cannot teach. Why? You give him this component, the supervisory component. You teach the academic component, the demonstration part. So there can be a mutual understanding and we can teach large number of students at any point of time. Confidence building in practical can take place minimum number of times a skill has to be practiced. I will tell a student has to do 10 delivery. Let the expert tell that okay, if he does 10 delivery himself, then I tell he can do it. Or enlargement of liver, he has to see 50 enlargement of liver. So we, in a distance education, everything is written in black and white. He has to practice this skill this many times under this setting and he has to maintain the logbook. So everything is structured. Independent performance, seminars, presentations, simulations wherever needed. Then integrate with workshops. If you feel resuscitation, how I will teach resuscitation? Do a resuscitation workshop. Let them attend 2 days. So depending upon the skill, depending upon the quality you want, these can be planned. Assessment of practical component. There has to be an internal assessment after a group of skills so that there is a continuum of the assessment. Certificate of proficiency. You see, even in the MD, at the end of 3 years we try to assess. And in the exam, even in the OSCE, you ask only 10 or 12 areas. You do not cover everything. But if a certificate of proficiency is given by the teacher who is training him, then everything is covered. Therefore, every group of skill certificate of proficiency, these are very important assessment tools for maintaining quality. Then the quality assurance, like separate examination for torment, practical, then external examiner 50%, like in the DNB we are doing. So all these are practiced in a ODL situation like in IGNOU. I will take 5 minutes more. Process of designing a program, I will not go into details, but the issue is we emphasize that a curriculum, like I was telling, we have to identify which skill to be taught for a MD family medicine. Once we identify these skills, we have to classify them, which are mandatory, which are desirable, which are optional. And our focus has to be in the mandatory skills. Like if you tell, like CGNA section, should it be taught? Maybe CGNA section will be optional category. But in the mandatory, we have to tell, okay, he has to know outlet for SEPs. So like that, those has to be categorized accordingly, the curriculum has to be designed. And what we do in a distance education, that like entry-level experience is taken into consideration, and accordingly, how much skill has to be built in, we plan it. I will skip these things. What is important? We repeatedly emphasize residential training is essential for medical training. My question is, for what purpose we demand residential training? Is it for theory lectures? Is it for clearing doubts? Is it for hands-on training demonstration? Is it for supervisory training for the hands-on training? Is it for self-practice? Or is it for attending emergency patients? All these I can do without residential training. I can do a better teaching by self-learning material than a theory lecture or by a multimedia video. I can do a better demonstration through video rather than hands-on demonstration. I can do a better training except supervision, which can be done in a district hospital, wherever patient is available. I only require the expert. I don't require the residency of the student. So what I want to emphasize, that wherever you feel no, for this purpose residency is required, fine. We can only have residency for that period of time. Maybe 10% of the duration, 20%, but never 100%. So this, our preconception that it has to be residential training, that has to be wiped out. Otherwise, we cannot scale up the training. We are talking about 20,000, 30,000 students are to be required, trained family medicine specialist is required. How can you train them? It is not possible if you do not follow the alternate strategy. The academic design is, there is a group learning in a medical college, there is a one-to-one mentoring or teaching in a district hospital, and there is an additional provision for slow learner. This is another very important point. Even in the best of the best, like AIMS, all the creams go to AIMS. Everyone passes or someone fails. If someone fails, why? It is because of this mechanism. We do not have a mechanism for slow learners. Distance education has that mechanism. If you do not have this mechanism, that means our teaching process is faulty. It is not the fault of the student. We have not taken care the learning problems of the student. We have not designed our curriculum as per the pedagogy that has to be followed. In distance education, these are the things we do: theory material, practical manual, audio video. We do program guide, standardize the teaching throughout the country through program guide. Counselor guide, standardize the teachers throughout the country. Administrative, all the administrative guidelines are standardized. That means you are standardizing, not only having a quality check, you are standardizing the training process. We follow the mechanism, like for theory teaching, we follow 1:30 student. Clinical posting 1:5, even 1:2 in our dental, like mentoring 1:1. So all these details I am not going to tell you, but what I want to tell you, distance education does not mean a second cadre of training. It is a quality check at every component. Rather, we are more meticulous. We ensure every skill is learnt by the student, not only by the best student, by the last student. That is the mechanism the distance education has. But the problem is, because we are not promoting it, so what is happening? This check is not there. Like you have giving the responsibility to a medical college. The medical college teacher will not do that checking. He will tell, okay, distance education, let him pass. Then who is at fault? Is it the system at fault or it is the implementer at fault? That is my question. Because we are not implementing it properly. And why we are not implementing? Because we are ourselves are not convinced. And we are blaming the system, which is very much required, especially in the Indian context, not only in India, for any developing country where there is a resource constraint, where we want to train large number of people at a short span of time in a cost-effective manner. Distance education is the tool which can provide the answer, provided we want to accept it and implement as we design it. I'll skip these things. In IGNOU, we have so many programs. These greens are the program right now we are offering, but we have experimented. If you see the varieties, we have experimented with all types of programs. With the Dental Council, with ICMR, with NECO, with DGHS, with Ministry, with everyone we have done the programs. Even at the MD level, we are giving the program, dialysis medicine. What I want to tell, like we are giving PhD in nursing. These are recognized by Nursing Council. So many allied health programs. But we have stopped most of the programs. It is because we find they are not finding to mainstream them, they are finding difficulty. Recognition issues or other issues. Therefore, we have put a block from our side. But if ministry wants, if the country demands that there has to be a scaled up training, let them work it, let them find out where the fault is and how the fault can be recognized, remedied. Then we can do the thing. So my message is all type of skill training, including surgical skill, can be successfully imparted through open and distance learning mode, which IGNOU has very well demonstrated by different programs. What I am advocating today, creation of a national health open university. What is happening? IGNOU is under Ministry of HRD, which is under education. Therefore, the health ministry does not have much idea about IGNOU. What is happening? It becomes a news. जैसे दिया का नीचे अंधेरा बोलते हैं. When I interact with the ministry, they are not aware that IGNOU is offering so many programs in Delhi itself. This is the tragedy. And how we expect that IGNOU will do miracles in healthcare. Unless we try to understand the mechanism, try to understand the process and its utility, we will not be using it. If there can be a separate health university, which will be linked with all the health open university, which can be linked with all the health universities in different states, then perhaps every health university can have a distance education unit, and let every health education material, there can be two modes of training. There can be a face-to-face training and there can be ODL mode of training, like evening college and day college. Same thing can be practiced in health training without compromising the quality, because same teacher will be teaching both the category. So all stakeholders of health manpower training in India must join hands in promoting ODL. Then only we can succeed.